Hello, and welcome to our Lunch and Learn series. My name is Giza Lopez, and I am the Executive Director of the New York State Youth Justice Institute. Let me thank each of you for joining us today in this virtual space and for making time to learn more about research into youth justice issues. Please feel free to introduce yourself to others in the audience by using the chat function. And as always, we are grateful to our partners in New York State, the Division of Criminal Justice Services, the Office of Children and Family Services, the University at Albany, and the New York State Juvenile Justice Advisory Group. Allow me to send a special shout out to my son, Sam, who is turning 17 today and is watching this webinar in the next room over. Happy birthday, Sam. You are a source of pride and joy for me every day. It is our pleasure to host Dr. Keith Cruz today. Like all of you, I'm looking forward very much to his presentation. It is delightful to have you, Keith. Thank you very much for joining. Without further delay, Brian, please take it away. Thanks.
Hello, everyone, and welcome to the Youth Justice Institute's Lunch and Learn webinar series. My name is Brian Rainey, and I'm a research fellow at the YJI. The goals of this webinar series are to 1, act as a source for cutting-edge research on juvenile justice issues, 2, to provide this information in an engaging and thought-provoking format, and 3, to bring together scholars and practitioners from various fields to explore these issues. I have one housekeeping item today. For those of us who would like to view a transcript of today, we will be providing a live transcription of today's presentation. Just follow the link that I will put in the chat in a few minutes, and you'll be able to access that live transcription. And with that, I think that we're all really looking forward to today's presentation, so I don't want to further delay hearing from a national expert in juvenile justice and trauma-informed approaches. Dr. Keith Cruz is a professor and director of clinical training in the Department of Psychology at Fordham University and co-director of the Center for Trauma Recovery and Juvenile Justice, a technical assistance center affiliated with the National Child Traumatic Stress Network. Dr. Cruz is also an adjunct professor of law at Fordham School of Law. He holds a PhD in clinical psychology from the University of North Texas and a master's of legal studies degree from the University of Nebraska. Dr. Cruz conducts research on the clinical forensic assessment of youth within the juvenile justice system. Various research projects have focused on developing and validating specialized risk assessment protocols, investigating the utility of mental health screening instruments with justice-involved youth, and understanding the connection between trauma exposure, trauma reactions, and delinquent behavior. Dr. Cruz's clinical forensic practice has involved providing direct care assessment and treatment services with justice-involved adolescents, conducting post-disposition assessments of risk and treatment amenability, providing expert testimony to juvenile courts, and providing technical assistance and consultation to local and state juvenile justice systems in implementing trauma-informed screening and assessment practices. Dr. Cruz has received grant funding to examine the effectiveness of enhanced mental health screening for poly-victimization, trauma-informed case planning, and the impact of trauma screening on service delivery and legal outcomes for justice-involved youth. So, without further ado, Dr. Keith Cruz.
Thank you so much, Brian, for that introduction. I often hear this, and I think, I'm like, who is this person? But very, very happy to be here and have the opportunity to join this Lunch and Learn series. And, kind of just start this out by saying that, my clinical experience has matched what has become increasingly clear based on available research evidence that adolescents that touch the juvenile justice system experience extremely high rates of lifetime exposure to traumatic events. And relative to adolescents in the community, these adolescents also experience elevated rates of current traumatic stress reactions and are often diagnosed with post-traumatic stress disorder. And what I really hope to accomplish with you today is to talk about the ways that the mental health field understands, identifies, and responds to traumatic stress reactions, and really offer my perspective on what I will call trauma-responsive services. Then my observations and opinions represented here will be a mix of research findings, policy perspectives, and built off of my clinical experience as well. So just expanding on that, really what I hope to accomplish in this brief time with you all today is to review current data on the prevalence rates of traumatic event exposures and current trauma reactions. I'd like to discuss how this information is linked to and that is to help us to understand our youth functioning. I'd like to highlight emerging best practices, particularly in the areas of screening, but also hit some highlights on treatment and case planning and some information about training of juvenile justice staff, and ultimately offer some suggestions on how we can support trauma-exposed adolescents who are system involved. Now, we've often heard this kind of big word trauma-informed, and I think from a systems perspective, I think it's important for us to get a little clarification on what we mean here. And I like to utilize the definition offered by the Substance Abuse and Mental Health Services Administration, especially as it relates to kind of a system approach. And so a program or organization or a system can consider itself to be trauma-informed, according to this definition, when it, one, realizes the widespread impact of trauma and understands the potential paths for recovery. Two, it recognizes the signs and symptoms of trauma in clients, family, staff, and others involved with the system. And three, responds by fully integrating this knowledge into daily practices, policies, and procedures. And fourth, actively, seeks to resist re-traumatization. And before we sort of dig in, I always think that it's kind of helpful to sort of set the stage maybe with a little case illustration. And we'll call this youth TJ. Now, when I met TJ, he was 16 years old and dressed in detention issue clothing. And I was conducting a mental health assessment to address TJ's current mental health functioning and to offer treatment recommendations as he was facing a discretionary transfer proceeding from juvenile court to adult court. A little bit of information about TJ. At age 13, he endorsed being in an accident with his older brother that resulted in serious injuries to his older brother. In referencing a war zone, TJ indicated his perception that, quote, the East Side, in reference to the city where he lived, was very similar to a war zone, specifically reporting the high crime rate, the number of shootings and killings that have happened in his neighborhood. That it also impacted his family, which had experienced 2 home invasions over the course of his lifetime. TJ reported experiencing family violence, witnessing family violence. He reported to me being shot at 2 different times in his community and being in multiple physical fights with other peers in his community as well. Witnessing community violence, TJ reported multiple instances of seeing others shot at or beaten up in his neighborhood, and specifically recalled an incident where he observed his mother being physically assaulted essentially at a convenience store that resulted in physical injuries. And by age 15, TJ indicated to me that he had experienced about 5 close friends or acquaintances who had been shot and killed. And expanding on that, that idea of traumatic loss or separation, TJ reported that the event that had the most impact on him was the loss of his paternal grandfather. He spent the day with his grandfather and decided to actually go hang out with his girlfriend. And later that afternoon, TJ received a phone call from friends telling him that his grandfather was killed after being stabbed repeatedly by another adult male at the grandfather's home. And like many youth who have endured multiple traumatic event exposures, there's usually one event, I think, that serves as kind of a tipping point. And for TJ, that was the death of his grandfather. Following this event, TJ spun into a period of depression, developed what he essentially described to me as a I don't care attitude, significantly increased his use of alcohol and marijuana and other prescription pills, stopped going to school, increased physical fighting in the community, began carrying a gun, and began engaging in a pattern of risky sexual behavior, and ultimately experienced his first arrest and contact with the juvenile justice system. So I'd like to just, after hearing a little bit of information about TJ, I'd like to, launch this first poll question. And essentially the question is, what would you estimate as TJ's risk for recidivism? Would you say that is sort of low, moderate, high, or very high? All right, and it looks like we've got, I think, almost everyone has responded. So Brian, if you want to cue the overall results. And yeah, and this is pretty typical to what we see when I talk about this case is, high or very high risk for future recidivism. And when I start talking to juvenile justice professionals in particular, I usually follow this up with a question is, are you excited to have TJ on your caseload as well? But ultimately, we also just really want to think about this in response to many of those traumatic event exposures, that I mentioned as well. But it's also really important for us, and I won't spend a lot of time here, but I also think it's very important as a field that we think about what I call unpacking trauma. We often use trauma as an umbrella term, and I often make the recommendation to others that we need to avoid that. And as an umbrella term, trauma is actually sort of incorporates a number of at least 3 key specific components. That's a traumatic event exposure. Then for some youth, that is followed up by a change in functioning that, and changes in the way that they think and feel and respond after a traumatic event. And those are what I refer to as active trauma reactions. And then the third component of this is a pattern of functional impairment, changes in the day-to-day functioning of an individual in the way that they navigate their environment based on these experiences as well. There are 2 other terms that I'll be referencing throughout the presentation today that are related to those 3 key components of unpacking trauma, and that's polyvictimization and also complex trauma. Why do I want you to know these terms? Because they are becoming quite common in the literature involving investigations of traumatic event exposures and trauma reactions among justice-involved adolescents as well. So let's spend a little bit of time thinking about what we know about traumatic event exposures. Well, like I mentioned before, research has consistently shown that traumatic event exposures or lifetime traumatic event exposures are almost universal among justice-involved adolescents. Between 90 to 95% of justice-involved adolescents, when queried, will have indicated experiencing a lifetime traumatic event exposure. And the types of endorsed traumatic events are pretty similar across boys and girls, with the exception of 2 events: experiencing family violence and sexual abuse. Females will proportionally report higher rates of these traumatic event exposures relative to boys. But when we think about things like being threatened with a weapon or physical assault or experiencing a violent crime, for example, these are all reported at rates between 30 to 60% across boys and girls. This slide here depicts a figure of the types of traumatic event exposures reported by a subgroup of about 600 justice-involved adolescents who were referred for trauma treatment. And what you can see is over on the right-hand or left-hand side of this slide, the types of traumatic event exposures that were most commonly endorsed were all interpersonal types of traumatic events: trauma, loss, and separation, domestic violence, emotional abuse, physical abuse, and community violence are all endorsed between 30 to 60%. The other very noteworthy thing, which has been replicated across many studies, is that the average number of traumatic event exposures is not 1, 2, or 3, but on average, about 5 different types of lifetime traumatic event exposures as well. And I think it's really important to think about this in the context of recent studies that have been emerging in the literature regarding adverse childhood experiences or ACEs. There are 10 different ACEs. Some of those ACEs are very consistent with those types of traumatic event exposures I mentioned, physical and sexual and emotional abuse, for example, but include other types of familial adversities, having a caregiver with mental health difficulties or substance abuse problems as well. And community studies have supported what I call a dose-response association. The greater the number of ACEs present in childhood have been associated over the lifetime with a multitude of physical, medical, and mental health problems. And there have been a host of studies, I would say, over really about the past decade, that have emerged that have investigated ACEs in juvenile justice samples. And Michael Baglivio and colleagues are really credited with systematically analyzing ACEs in a sample of over 64,000 justice-involved adolescents in Florida. And there have been studies published by other colleagues as well, finding a similar dose-response relationship. And particularly in justice-involved adolescent, these number of ACEs have been linked to things like active suicide ideation in adolescents, gang involvement, self-reported offending, official arrests, and also an association between general and violent recidivism as well. And a recent systematic literature review published by Graff and colleagues, it's just published in Pediatrics, essentially found significant association between ACEs and justice involvement in 13 out of their 15 studies. Now, this is very important research for us to continue to follow, and finding that there is this association between adversity and traumatic event exposures in childhood and justice relevant functioning in adolescence. And while this association has definitely been found, I think it's really important to note that there are probably multiple intervening factors that help us to understand why this association exists. And this body of ACEs work is very consistent with the term polyvictimization that I mentioned. And polyvictimization refers to adolescents, children and adolescents who have been exposed to multiple different types of victimization experiences. It's ignoring the frequency of any one individual type, or the frequency of example of like a trauma loss, et cetera, and looking at the breadth of traumatic event exposures. This is very consistent with that idea of the dose-response relationship with ACEs. And similarly, research has been showing that polyvictims are at a great risk for all kinds of psychosocial impairments in childhood and adolescence, and even adulthood as well. And specifically, polyvictims are seen to be at an increased risk for PTSD and depression, specific mental health problems. They're actually seen to be at an increased risk for chronic medical diseases. They're about 4 times more likely to be re-victimized in adolescence as well. And very relevant to our discussion today, youth who are polyvictims are at an increased risk for anger, aggression, and impulsivity. And if there's one thing that we know that is likely to increase the likelihood of some connection to the juvenile justice system, it's probably anger, aggression, and impulsivity. And of course, this leads us to a discussion of trauma reactions. And clinically, we could think about this as being most consistent with a diagnosis of post-traumatic stress disorder. And what do we know about the prevalence of PTSD? So in a study that we just recently completed with 132 detained adolescents in a southern state, we found a current rate of PTSD detected using a structured interview of about 23%. In a recent systematic literature review, summarized 21 studies that reported PTSD diagnostic rates in about 16,000 detained adolescents, and found a diagnostic rate of 8.6% for boys and 18% for girls as well. And this is a very consistent result that emerges across studies, finding higher rates for justice-involved girls relative to boys. But even looking at that lower number for boys, that's still about 3 to 4 times higher than rates that are reported among non-system involved adolescents in the community. And comorbidity or diagnosis of multiple mental health disorders on top of PTSD is quite common. In fact, 93% of detained youth with PTSD in one study met criteria for at least one other mental health disorder. But it's not just the specific rate of PTSD that we need to be concerned about. Returning to that subgroup of approximately 650 justice-involved adolescents, this study found a rate of PTSD around 23.5%. Now, I think that's a slightly higher estimate because these youth were all referred specifically for trauma treatment. So somebody had likely, determined that there was some specific, functional impairment associated with trauma and referred them to treatment. But this slide really shows is once we start breaking down the diagnosis of PTSD into specific types of trauma reactions, those intrusive recollections or memories of the traumatic event that pop into an adolescent's head, that internal or external avoidance of thinking about, or being reminded of the traumatic event, and the negative changes in cognition and mood. And that's basically changes in the way that an adolescent thinks about themselves, thinks about others around them in their world, or that arousal, that classic hypervigilance, or that risk-taking behavior, or that anger, aggression, and impulsivity. This figure shows the rate of clinically significant trauma reactions fitting into these different categories that ultimately can lead to a diagnosis of PTSD. And what you can see here is that they're endorsed at extremely high rates, between 50 to 70%. And so I think that's really important for us to recognize that it's not just the overall diagnosis of PTSD that we should be concerned about, but we should be thinking about the types of functional impairment that can be associated with day-to-day experiences of these types of active trauma reactions. And ultimately, I think this type of information about the prevalence of traumatic event exposure and trauma reactions has really led us to think about how we can respond. I had the privilege of working with a series of colleagues through the National Child Traumatic Stress Network, where we developed a document that we called the Essential Elements of a Trauma-Informed Juvenile Justice System. And I'm sorry, the link for this got a little messed up in the formatting here, but I'm sure that can be lifted and offered to you in the chat. This is a publicly available document through the NCTSN from their website, and identifies 8 different essential elements of a trauma-informed juvenile justice system. One of those is screening and assessment. One of those elements is essentially that all adolescents at the point of initial contact with the system receive and can be screened for traumatic event exposures or active trauma reactions. And for the sake of time today, I won't want to be digging into any of these screens in particular, but just wanted to offer them as an example of the different range of different types of screening tools, that there is some and varying levels of research evidence about their use within the juvenile justice system. And screening about trauma is on the rise. And what we also know is that there's been a rapid rise in the increase of use of structured risk needs assessments by juvenile justice professionals as well. This is primarily used to guide case planning. And a key question, I think, for me in my research and also in working with systems is to think about the extent to which these tools could be considered trauma-informed. And what you can see from this slide here is that there is varying coverage in terms of items listed on 3 common risk needs assessment tools that are currently utilized. But from this, if tools don't really cover this very well, we can think about the model that is predominantly used in the juvenile justice system to engage in case planning, and that's the risk needs responsivity model. And sounds very fancy, but it really does boil down to 3 pretty basic principles. The risk principle. It's basically the idea that the intensity and dosage of treatment services should reflect the use assessed risk for future delinquent behavior. The needs principle basically says, once we determine the dosage and intensity of treatment, we need to think about what intervention targets. And this model says that we need to focus on those dynamic, changeable, empirically supported risk factors for future delinquent behavior. But we need to do that in a very responsive way. And the responsivity principle says that we need to think about the general features of intervention or treatment as primarily being assessing skills, and most likely using like a cognitive behavioral therapy format. But then we also really need to think about those interventions as addressing what are referred to as specific responsivity factors. Those are characteristics or circumstances not directly related to offending, but because they are on board, they can destabilize a youth's functioning and then require attention in terms of a case plan. And what I can mention to you today is that most mental health factors, depression, anxiety, and trauma reactions or a diagnosis of PTSD are best considered from within this framework as a specific responsivity factor. And so linking this back to the information about risk assessment, without appropriately attending to responsivity factors or trauma, specifically for our discussion today, we have some challenges here, right? A risk assessment tool could really identify some components, maybe about traumatic event exposure or trauma reactions, but it's unlikely to really signal the complexity and duration or severity of those responses for you. The overall risk level for future delinquent behavior may be really accurate, but a risk formulation and management plan, may not be accurate. It may not be a well-matched, given the presence of trauma as a specific responsivity factor. And I think that this can lead to poorly matched treatments or placements as well. I think it can lead to some confusion about, regarding how should we think about trauma as risk and need if it's not appropriately conceptualized. And ultimately, from a systems perspective, we need to be concerned about the potential for net widening, bringing youth formally processed into the juvenile justice system, out of the goal of potentially getting them access to treatment, but also bootstrapping. If there's limited evidence from a tool or an assessment approach about risk, about prior traumatic event exposures or trauma reactions, this could be used to infer something about the severity of difficulties, and also lead to some concerns about a net widening as well. I think here's a very practical example of some of these concerns when it comes down to juvenile justice case planning. From my lab, we conducted a study, in a northeastern state where we had 147 juvenile probation officers review a case vignette. They rated the YLS-CMI, that risk need assessment, and they actually developed a case plan. What we did, though, is we varied that case vignette by gender and the presence or absence of traumatic event exposure history and active PTSD symptoms. Now, what was evident from this study was that once we looked at the delinquency risk factors from the tool and the match to case plan, we found a very high match. Juvenile probation officers developed a case plan that really sort of targeted those high dynamic risk factors that we know are connected to recidivism, things like substance use, things like educational problems, things like negative peer involvement as well. But what's important to know is that 75 of those juvenile probation officers also had information about trauma, traumatic event exposure, and trauma reactions. And out of those 75 juvenile probation officers, only 3 identified anything about trauma as a relevant target on the case plan. And so I think this is just really represents and kind of reinforces the need for us to think very critically and carefully about how things like trauma screening and trauma assessment can be integrated alongside case planning to address delinquent behavior. And if we think about that from the risk needs responsivity model, I've just offered you a figure here down at the bottom representing actually, I think, the complexity, here as well. And there are sort of 3 conclusions that I'd like you to draw from this slide. Under this model, we can think about criminogenic needs and the load of criminogenic needs as being a direct sort of correlate or predictor of future recidivism. And that's that bottom line, that connection between criminogenic needs and reoffending. From within this model, we think about like active trauma reactions or PTSD symptom severity as a specific responsivity factor is unlikely to directly predict reoffending outcomes. It's those dynamic criminogenic needs, which we know from other research, is what accounts for that effect. But as a responsivity factor, active trauma reactions are likely to aggravate or exacerbate that criminogenic need connection and reoffending. And what some current research that I've been doing from within my lab really shows is that there is a complex interaction between traumatic event exposures and criminogenic needs like substance use problems, family problems and difficulties, negative peer group involvement, educational problems. And that there's probably a bidirectional relationship between those trauma reactions and those criminogenic needs that if not taken into account when we think about case planning, could reduce the utility or the effectiveness of our typical justice interventions at reducing risk for future delinquent behavior. And unfortunately, we've got a lot of, we have a lot of studies that address sort of the utility of risk needs assessments in designing case plans. That's the risk principle and the needs principle. We have less information on responsivity factors. And here's one example of a study that looked at 100 adolescents equally balanced across boys and girls, and looked at the extent to which there was an association between specific forms of maltreatment and childhood adversity and future recidivism. And what this study essentially found is that only maltreatment and the load of childhood adversity was correlated with total risk scores measured by the risk needs assessment tool, in this case, the Youth Level of Service Case Management Inventory. And maltreatment was the only significant predictor of recidivism 2 years post-assessment in this model, alongside criminogenic needs. Active trauma reactions were not. Now, there were some limitations to this study that I think might have precluded the researchers from really understanding the complexity of this interaction between trauma reactions and maltreatment. But this is highly consistent with that prior ACEs work that I mentioned as well, finding that early childhood adversity is associated with future recidivism. Now, this is a terrible slide here, I recognize, but I want to try to unpack this in a minute. Now, Dr. Evan Holloway, this is the results of his dissertation study conducted within my lab, looked at a sample of about 320 detained adolescents and looked at understanding and unpacking the different patterns of traumatic event exposures and delinquency risk factors through a process that's referred to as latent class analysis. And once we start looking at this combination, we find three different groups. A group of youth represented by the green line, very low on traumatic event exposures, but very high on delinquency risk factors as well. The second group that is represented by that orange line had a moderate load of traumatic event exposures, but also sort of lower overall dynamic or risk factors as well. And then we had, and the group that I'd like you to pay attention to is this contrast between the green and the blue lines here. This green line represents the subgroup of adolescents, represented about 25% of the sample, very high on the blue group, very high on traumatic event exposures, and also very high on specific risk factors as well. And so, pointing to the horizontal arrow here, what we see is that this different class membership was really reflected is that we got two subgroups of adolescents who were very high on delinquency risk factors. That subgroup can be divided between those who had very high traumatic event exposures and those who did not. This class membership was associated with PTSD symptom severity as well, finding the highest PTSD symptom severity in that subgroup represented by the blue line that also had a very high load of delinquency risk factors as well. To me, this type of study really reinforces the need for likely that if there's going to be a subgroup of very high delinquency risk adolescents who are going to need access to trauma-specific treatment services in order to try to achieve some delinquency risk reduction. I've also been engaging in some use of assisting juvenile justice professionals of trying to unpack some of these relationships through the development of something I refer to as the trauma-informed decision protocol. It's a 9-step decision-making framework that allows a juvenile justice professional to integrate results from a risk need assessment, trauma screening, and other types of mental health screening as well. It's grounded in the R&R framework as well, and really allows a juvenile probation officer or juvenile justice professional to do sort of a deeper integration and consideration of trauma, traumatic event exposure or trauma reactions as specific responsivity factors. And ultimately, this is designed to think about access to case planning. Now, I'll talk about a couple of findings from our work with this tool. The types of criminogenic needs or dynamic risk factors that are being seen as most impacted by traumatic event exposures and trauma reactions are things like personality and behavior difficulties, negative peer group difficulties, and substance use. And probation officers are showing the highest level of concern ratings about specific traumatic events, emotional abuse, family violence, and specific trauma reactions, avoidance, and those negative alterations in cognitions and mood and that arousal. And what we're finding is that a probation officer's level of concern scores that can be generated from this tool are associated with probation officers' likelihood to be recommending some sort of further trauma follow-up in the form of assessment or treatment. And what we're finding in a small feasibility study is that implementing the TIDP at probation intake resulted in about a 2 to 3-fold increase in the number of case plans that included a recommendation for trauma services compared to case plans done prior to the TIDP implementation. So let's hit that poll question, and then I'll conclude with a summary here. This next poll question is, via this idea of the risk needs responsivity model, active trauma reactions are best considered as what? A static risk factor that doesn't change, a criminogenic need or a dynamic risk factor that directly impacts recidivism, a responsivity factor that may indirectly impact recidivism, or a strength that buffers risk. A little more complex poll question here. I apologize, it gets a little wordy, but I'm able to see that we have lots of people, responding here. We'll wait give it another minute. All right, I think we're about over majority here. And so Brian, if you want to end the poll, and it's looking like the most common response here at 67% is exactly that, a responsivity factor that may indirectly impact recidivism risk as well. Excellent. And so I've been talking a lot about this idea of a screening and assessment integration with typical assessment processes used in juvenile justice, but haven't really yet talked about treatment. For the sake of time, I'm just going to point you to a really nice systematic review that was published in 2019 that reviewed 16 studies involving the delivery of trauma-specific treatment services in juvenile justice settings. And, there's a consistent finding that has emerged across these 16 studies, is that the delivery of trauma-specific interventions across different types of juvenile justice settings are consistently finding a significant reduction in those active trauma reactions or PTSD symptoms after the intervention is completed. And this is what we would expect to find as well, given the evidence base for these interventions among non-justice involved adolescents as well. But I think it's important to note that the current limitation of this work is we actually do not yet really have a good connection of the impact of treatment on forms of externalizing behavior or ultimately on recidivism. These are studies that I know that there are some that are ongoing, but yet just haven't been done yet. I want to point you to a couple of other resources, given the audience here that are available. If you're really interested in thinking about that idea of a trauma-informed systems approach, I worked with colleagues through the NCTSN to develop a tool that was released in 2019 called the Trauma-Informed Juvenile Court Self-Assessment. It is informed by the essential elements and essentially operationalizes them for a system to be able to sort of benchmark and review how well they are doing in terms of day-to-day practices and policies along those essential elements. For those of you who are interested in staff training, the NCTSN has an amazing curriculum. It's a module-based training for juvenile justice professionals called Think Trauma. It covers information about trauma and delinquency, trauma's impact on development, coping strategies, and vicarious trauma or secondary traumatic stress and the importance of self-care. I will also mention, I don't have a slide for this, but I recently participated and recorded a podcast through a podcast series called In Defense of Children. That episode just dropped this past week, where if you're interested in hearing sort of an interactive discussion on some of these topics I've represented here today, you might be interested in taking a look at that podcast. And I think Brian will be posting a link to that in the chat as well. So I just want to conclude here with some take-home messages for you to consider. Now, hopefully what you can see here, and I think this is very consistent with the idea of the risk needs responsivity framework, is that I do not think, and the research doesn't support, that traumatic event exposures or trauma reactions should excuse delinquent behavior, but I think can really help us to understand delinquent behavior. Traumatic event exposures and trauma reactions, I think, are best considered as responsivity factors. And because of the prevalence and load and interaction with other delinquency risk factors, is we need to think about integrating this into case plans for youth at whatever point of justice system access they find themselves in. And of course, the challenge is to really consider what events and what reactions are really driving and are associated with that idea of delinquency risk, and then how we can best match them to services as well. And I think with that, to try to reserve some time for questions, I'll stop there. And of course, I'm going to include my email. We'll leave this up here momentarily. I always welcome, future contact from others interested in throwing some questions my way.
Great, thank you so much for that, Dr. Cruz. Some of you have been putting questions in the Q&A section. Thank you for that, and I encourage you, if you have any questions for Dr. Cruz, to submit those in the Q&A section, and we will try to get to those during the audience Q&A. But before we get to that, we do have the informal conversation portion. And so in your presentation, the fourth R of a trauma-informed approach was resist re-traumatization.
Yes.
For everyone in an organization, they strive to avoid re-traumatizing youth. Given that trauma can be so individualized and personal, do you have any tips for tailoring approaches to avoid re-traumatizing youth?
Yeah, and I think I think there's a couple of things to really comment there. Is individualizing at the systems level is really complicated. And so when we think about that prevalence of traumatic event exposure as being so high, and about, between 30 to 40, between about, 15 to 25%, of youth coming into the juvenile justice system with active trauma reactions, I really recommend at the systems level, really thinking about a universal precautions approach. We really want to think about what are ways that youth might be triggered, from our system involvement, either intentionally or unintentionally as well. And what I also think is important to note, and I really, for sake of time, really didn't unpack this much, is we often get really concerned about, re-traumatizing a youth, that's spinning them off through our interactions or involvements of, and activating maybe that stress response or active trauma reactions. And yes, it can happen. But I think what's also really important to note here is that, is if the youth is in front of us, it's, even though that they may be experiencing active trauma reactions, they are a survivor. They have lived through their experiences of their traumatic event exposures. And if this was a universal response, what we would see is we would be seeing PTSD rates of above 90%, right? And so what that's really important for us to recognize is that not all youth who have experienced traumatic event exposures are going to suffer from active trauma reactions that are going to be destabilizing etc. And that just, I think, speaks to the resiliency of many youth. And what's really important is to remember that and to think about ways of tapping into positive coping that a youth may have experienced that as well. But if we're operating in a system that is oblivious to this, we can be inadvertently, exacerbating or exposing them to some common triggers that's going to set off, at a minimum, a stress response, and for some youth, an actual trauma reaction.
So related to sort of tailored approaches for assessing trauma, you also noted the importance of considering context when looking at trauma history, treatments, and placements. So what different kinds of context should be considered, and how can practitioners better incorporate context into these tools?
Yeah, I think and when I think about context, I think it's really important for us to think about distinguishing traumatic event exposures as really falling into two different broad buckets: interpersonal, interpersonal types of traumatic event exposures, and non-interpersonal. And what we can see is that interpersonal traumatic event exposures are actually the most common. And if we think about this, it kind of makes sense. For children and adolescents, where do they spend their most time? In the context of their families and caregivers, in the context of their interactions with peers in the community as they get a little bit older as well. And we really need to think about where the traumatic event exposures were experienced or witnessed and the likely impact of that. Research has shown over and over again that interpersonal victimization experiences carry a greater risk load for the development of psychosocial problems and difficulties. But ultimately, for both physical and psychological safety, we need to think about the context of where these exposures came from and what may be really driving those active trauma reactions when we start thinking about our work with adolescents.
Yeah. So during our COVID-19 and Youth Forum last year, it was mentioned that individuals who commit violent acts are often victims of violence themselves, who have experienced traumatic events. In other words, hurt people hurt people. Mm-hmm. And it's also common knowledge that the nation as a whole has been experiencing increased rates of violence. So what role do you think trauma, including the collective traumas that many have experienced over the past couple of years, including because of the pandemic or violence against communities of color, what role do you think trauma plays in this new pandemic of violence?
Yeah, I think it certainly, I think, is a contributing factor, but I think it's really complex as well, right? Everyone has experienced stress associated with the pandemic, and then when you think about that level of stress added on top of the experience, like I've been talking about, of other types of traumatic event exposures, right? It further taxes our system. And I think it increases the likelihood of an adolescent experiencing problems with overall self-regulation. And when you experience overall problems with self-regulation, you don't handle stressors well. You don't handle frustrating situations well. And then if that's occurring in the context of a community where there's access to guns, gang violence, community violence, I think it is increasing. It's increasing the likelihood of violent reactions. And I'll just tie this back to TJ as a case example. TJ is a good example of a youth that meets sort of paradoxically this hurt kids, hurt other people as well. And I've consistently found this in my clinical experience, and I think this is also borne out in some research as well, is that some of the most traumatized youth who come into contact with the juvenile justice system are youth with some very high rates of aggression or engagement in violent acts charged as violent crimes as well. And that was the context where I met TJ. He was actually charged with first-degree murder, as well. And this is challenging for the system. It's really challenging for the system to think about the severity of an act like that, and then also be hearing information about trauma. And some people may say, how is it at all relevant that this youth is experiencing PTSD symptoms when they've also engaged in this type of act. And I think it's important for us to really further unpack and then think about in what ways did a youth like TJ's functioning change after the experience of traumatic events? How did it shape the way he was thinking and feeling? And then how did that map onto his engagement in delinquent behavior? It's complex, and it's a complex sort of process. And this is where it really reinforces my idea is that, it can't really excuse that history or those current mental health problems can't really excuse TJ's engagement in that act, but it can help us to understand some contributing factors and ways that we might think about intervening.
Thank you for that. So I think it's time to get to the audience questions. So the first question is, do you have any suggestions as to how the juvenile justice system would reconcile the findings that you discussed with seeking justice for victims of crime?
Seeking justice for victims of crime. Yeah, it's, there are, that's a very important question, because when we think about this I take a twofold perspective here, is that we as a system need a balanced approach of supporting victims of violent crimes while also supporting and really working on violence reduction and offending treatment as well. We can't ignore the victims of violent crimes. But if we're really thinking seriously about a way to support victims, we have to think about balancing that with appropriate, and for my case and my lens around this is supporting adolescents who engage and create victims through their violent acts as well. I'm a strong supporter of, efforts at restorative justice and principles as well. I've not seen good evidence around that specifically in relation to youth who have experienced traumatic event exposures, but ultimately see that many youth are aware of the harms that they've caused to others, through their violent acts, even if it can be explained in some way by their trauma. And I also think that part of their recovery and offered through appropriate treatment is first developing skills that would move them and manage those reactions, and then eventually thinking about, integrating in an awareness of the harm that they have caused others, through their actions as well.
Do you have any thoughts on what underlies professionals' reluctance or resistance to considering trauma more in case planning? Such as lack of awareness, a devaluation of the impacts of trauma, or something else?
Mm-hmm. I think it's a number of factors that I see it in my work. I'm very pleased to say is that, and maybe it's just the systems that contact me for some of this work is I don't have to convince them that trauma is a real thing and that it's real and that it can have an impact on you. I've seen a definite shift over the past 10 to 15 years. With greater awareness around this. I think the struggle is exactly what I mentioned, is juvenile justice professionals and even treatment providers that work with justice-involved youth are much more aligned around the externalizing behaviors, the aggression, the anger, the impulsivity, working with families or caregivers around more appropriate supervision and communication. These are observables. These are things that are easy to pinpoint. They're easy to measure, actually, as well, right? And what's harder is to really think about the overlying mental health difficulties and it's the extent to which they can be destabilizing. I also think the research is still too far behind as it comes to supporting what role does trauma treatment play in achieving some delinquency risk reduction. So I think it's a combination of multiple factors. But ultimately, this is why I've been trying to do some of this work, is to raise some of that awareness with some idea that, yes, we do have treatments that can work in reducing trauma and reducing those trauma reactions and improving self-regulation. And I think ultimately, as opposed to thinking about that as having a direct impact on recidivism, we want to be really thinking about that as how is that reducing and assisting the system in addressing those delinquency risk factors? Because ultimately, that's our approach. We want to reduce those delinquency risk factors to better place the youth on a trajectory towards more positive functioning in the community. And I do think that for some youth, trauma treatment has a role to play at addressing some of those factors.
So earlier you mentioned restorative practices or restorative justice. So how do you see restorative justice as a method of re-engaging youth with the communities on whom the violence was committed? Do you have ideas for steps in the process, given what you study?
I think there is a place for it. I also think, and this is my opinion, and just thinking about clinical functioning and how trauma treatment works. I don't think a youth who's experiencing active trauma reactions and a heavy load of traumatic event exposures is going to be ready for a restorative justice approach until that they have developed enough active coping around those trauma reactions. You know, what we know about that stress response and trauma reactions is it essentially narrows a youth's focus into what we call chronic survival coping. They're less concerned about others, and they're more concerned about their day-to-day survival and how they're navigating through that day. And if we're asking them too early to think about a restorative session or sessions with someone who they have harmed, when they're experiencing that chronic survival coping, it's unlikely to have the impact that we would want it to have on the youth. And it's probably also unlikely to have the restorative impact on the victim or the person who has been harmed as well. So I think it's really one about potential sequencing and should become potentially available as part of that moving forward after appropriate components of treatment that focus on that, active skills around stress reduction and active coping around the emotional arousal that we see in youth experiencing trauma reactions.
Well, I think that's all the questions we have time for right now, but Keith, I'd like to thank you on behalf of the YJI and everyone in attendance today for taking the time to share this crucial information with us. But before I get to the closing announcements, do you have any last thoughts for us?
Couple of last things, and I often end with this as well, is that, consistent with that idea of kind of a universal precautions approach, is I think it's important for everyone who works with a justice-involved adolescent to anticipate stress responses, right? And that it's helpful for us to think about what are the types of things that can inadvertently trigger that stress response or trigger an active trauma reaction, and ultimately, don't overlook resiliency. If the youth is in front of you right now, even with this history, at some level they are a survivor. And I think it's important to be mindful of that and to recognize is that although they might be on a pattern of difficulties and some negative coping, they've likely experienced episodes or elements of positive coping from within their history. And that is just as important for us to try to tap into from a case planning and a treatment perspective.
Thank you, Keith. And before we close, I do have just a few announcements and items to put on everyone's radar. The next session of the Lunch and Learn series will be on September 20th at 12 p.m. Eastern Time. We'll be hosting Dr. Nancy Rodriguez, professor in the Department of Criminology, Law and Society at the University of California, Irvine, and Margaret Goldman, a PhD student in the same department. They'll be discussing the current state of research on the overrepresentation of youth from certain racial and ethnic backgrounds in the juvenile justice system. So be on the lookout for registration information for this webinar session. The YJI also has an ongoing podcast called Let's Talk About Youth Justice. The inaugural episode features a conversation with Dr. Timothy McCuddy, who spoke with me about traditional bullying, cyberbullying, and issues related to both. Alicia should be putting the link for the podcast episode in the chat section. We have been in the process of producing new episodes of the series this summer, so be on the lookout for new content from us. From June 1st through 3rd, 2021, the Youth Justice Institute was honored to convene a 3-day virtual forum titled Beyond 2020, The Next Normal, COVID-19 and Youth. The forum brought together researchers, policymakers, and practitioners to assess the system and community level adaptations implemented during the pandemic and to explore potential next steps that can ensure for the youth justice field emerging out of the pandemic, ensuring that it is more just, equitable, and wellness-oriented than what youth and families experienced before 2020. The recordings of the keynotes and panels are now available on our YouTube channel, and we will be putting the link to those videos in the chat momentarily. Shortly after we finish here, we will be sending a survey to you all via email. If you have the time, please complete this survey as it allows you to provide further feedback and questions for us. This information will be used to improve future webinar sessions. The survey should take no longer than about 5 minutes, and we will also be putting the link for this survey in the chat momentarily. Finally, if you've not already done so, feel free to connect with us on Facebook, Instagram, Twitter, and LinkedIn. The links to those accounts can be found on our website. And just a reminder that the views expressed here are those of the presenter and do not necessarily reflect the views of the New York State Youth Justice Institute. And in closing, I just want to thank you all for taking part in this session of the YJI Lunch and Learn series. We hope that you've gained something from this webinar and that you continue to think about the work that Dr. Cruz has presented today. We also look forward to seeing you at future YJI events and webinars. Thanks again, everybody, and have a great rest of your week.